We looked at a cohort of about 130 AML patients. The rationale for our work was data from the group of Dr. Maggetti and others who also were at this meeting, that in many patients, AML comes from a so-called preleukemic clone. That is a group of cells that already have some of the mutations that the leukemia has, but it's still capable of normal differentiation if you look at it under the microscope. Now, some people have found if you treat an acute myeloid leukemia with chemotherapy and the patient goes into remission, such a preleukemic clone can persist in the bone marrow and make up quite a substantial amount of your hematopoiesis in remission. So our question was, do these preleukemic clones associate with clinical characteristics and importantly, treatment outcomes of our patients? So in these 129 patients that we looked at, we started by looking at the driver mutations in the leukemia at diagnosis. We then went back when the patient entered a remission and checked whether we could still find those mutations. And actually, in about 40% of patients, some of the mutations present in the leukemia clone were still present in a morphologically normal remission marrow. And these 40% of patients had significantly higher incidence of relapse and shorter survival than those who cleared all mutations in the relapse. When we looked at this a bit more closely, we found one important point was that the patients who had persisting mutations in the remission samples, they tended to be quite a lot older than those who cleared all the mutations. That is interesting because we also know in apparently healthy older persons, there's a high incidence of clonal hematopoiesis. So there seems to be a parallel there. And our conclusion is that these leukemias, which originate from preleukemic clones, may be biologically distinct and more difficult to treat. One other important factor is that we looked at how our patients were treated after remission, what happened to them after they had induction and went into complete remission. Those patients who did not receive an allogenic transplant and had persisting clones actually had a very high incidence of relapse. Those that did receive an allogenic transplant, they did much better. So this is retrospective data. There's a lot of risk of confounding in these analyses, but with that cautious note, it may be that the detection of a preleukemic clone in remission could be a trigger towards giving your patient an allotransplant if the patient is able to receive one. Now, since I said these are often older patients, we will have a population of very old patients who are not fit for an allotransplant and still have these persisting clones. And there we need to look at them more closely and develop new strategies how we maybe can eradicate these clones.